Okay, then we go on to the next part of it, blunt trauma to the anterior segment. I think that's a big subject and the right person to tackle it. Purendra, President Bhasin, who's also the Senior Vice President of the Ocular Trauma Society of India.
Thank you, sir. Anterior segment injuries. Um, Really, it's a big subject. I will touch some part of it in my way, and this will be a case-based presentation. So, cases can present like this in variety, and they all are really looking bad to begin with. And but ultimately, we can give good vision if we do manage these cases in a better way. So my first case is a 35 years old lady. She had an injury with a green stick, wooden stick, in the left eye, followed by pain, redness, and decreased vision. And the vision was 2 by 60. She presented to us uh, late, and by that time she had this kind of a picture. And this is a layer of dematiaceous or pigmented fungal keratitis, which was examined. And the management goes as like a topical and systemic antifungals and antibiotics are given. And we gave intrastromal voriconazole also along when the sheet was present. And then we did a therapeutic scraping, and in a scraping, like we did later on, we did a superficial keratectomy, and this is the ASOCT before, when this plaque was there, plaque-like thing was there, and this is the OCT picture, and this is how this whole thing came like a plaque, which from chapati jaise hoti hai, it came out of it, and we did, in between we had to dissect it uh, with the knife and with the blade, and this is how we did a superficial keratectomy. And after this, the penetration of the drug started in a better way, and the patient healed with some haze, and this is the post-operative ASOCT. There is a thinning in the region of the keratitis or the fungal keratitis region. Another case, 35 years old male, had a penetrating trauma. Corneal tear repair was done at some other place, and the patient came to us with the presence of pseudoterism at 6 o'clock with a 16 diopter cylindrical power, and with cataract formation, and there was an iris defect present. And 6 months after the primary repair, we planned, this is how the IL master reading was. So 6 months later, we planned for the cataract surgery with 11 diopters correcting IUL. And this is how the patient looked when we did the cataract surgery. So we released all the anterior posterior synechias, and performed the capsular access, gentle hydrodissection. Case was soft cataract. But here you see, while I was aspirating the cortex, we find that there is a vitreous present in the region where the. So immediately we came out and filled the chamber with viscoelastic. We used aniridia rings, and these rings, they decrease the size of the pupil, as well as they worked as a of the capsular bag. And with this 11 diopters correcting IOL was placed. This is from Rayner company, and patient got rehabilitated with some residual astigmatism. Later on, after 6 months, we released the pseudoterism, and we found that the sutures were present there, and we released those sutures also. And then the patient improved to 6/9 vision with minus 1.5 diopters of cylindrical power and zero point 0.5 diopter of sphere. So another case, this is a firearm blast case, injury case. This child, 17 years old male, was enjoying the marriage function, and during the marriage function, you see atishbaji hoti hai. This fire, this thing is there. And at the same time, some local firearms are also there. So this is something which happened to this young child of 17 years old. He came to us with bilateral PLPR vision. Intraocular pressure was 18 in the right eye and 40 in the left eye. And the picture was that multiple embedded foreign body over the skin and over the forehead and in the cornea and sclera. So right eye there was a sealed corneal tear, and in both eyes there was a traumatic mature cataract with ruptured anterior capsule, and on B scan we could find there were vitreous or intraocular foreign body in both eyes. So this was the picture. So this is how we went. We took left eye first because that the pressure in this eye was normal, and we managed medically in the other eye. So you can see there is a floating intraocular foreign body, which I thought I will be able to catch it, but it suddenly went behind. And then with the help of vitrector, there is a primary PC rent. We did this case, and after a week, my retina surgeon, he removed this intraocular foreign body, and the patient was kept aphakic. Now with this experience, this is the right eye of the same patient. So primary sealed corneal tear were reinforced by the sutures, and we have placed a infusion at the pars plana to float this foreign body because it was there in the other eye. So, and that similar kind of foreign body was there. So with the help of paracentesis, this iris is coming out because there is a pressure from behind because of the infusion cannula. So we sutured it, and then with the vitrector only. Mind it, we can do it with IA, but vitrector gives us the facility that we can cut the vitreous along with and remove the cortex also simultaneously. So this eye, after the 2 months later, we released the synechias, adhesions, and this was the left eye, and we did a secondary implantation. This was the better eye, and the optic capture was done in the capsular axis, and in the right eye, which was where the multiple tears were there. So we did rehabilitated this patient with the help of secondary IOL implantation because there was not adequate capsular support. So we did a Yamane technique and rehabilitated. It's your choice, whichever way you want. You can go for a retro iris fixation or the glued IOL or anything. That is your choice. And we rehabilitated this patient. And in this eye, there is a residual refractive error post this thing surgery. But in right eye, the patient is having 6/9 vision. In the left eye, which best corrected vision is 6/12. So coming to the cases of intraocular foreign bodies. So they come to us when you see there is a sealed corneal tear, and with the corneal tear you see some hair-like things are there, and these are eyelashes. There are 2 eyelashes. They have to be removed because they will create a reaction inside the eye, and one more eyelash is there after this, and then the surgery is performed, and like now this child, 7 years old male, came to us with the injury by the pencil. His friend, nowadays there is a lot of arrogance, even in the children there is arrogance. So his friend in the classroom, he poked pencil into his eye. So this is how the patient came to us from some 600 kilometers away, and there was a large foreign body embedded in the lens, and this is a lead of the pencil, such a big foreign body. And it was so difficult to release all these adhesions because the lead induces lot of inflammation, and we just cut it, all these the fibrosed the lens matter and the fibrosed posterior anterior capsule, and the adhesions of the iris with the lens matter and the cornea, and released everything, and removed all the cortical matter, and placed a PMMA lens, because my opening was already large for removal of the, so, and I was not sure of my capsule support, so I placed the lens, PMMA lens, in the sulcus. And this patient had severe inflammation in the post-operative period, severe fibrinous reaction in the eye, and which persisted for almost 2 to 4 weeks. And but fortunately, it was not endophthalmitis. Fortunately, it was not. It was restricted to the anterior segment only. It didn't. It was not in the posterior segment. So we were very sure of that it is going to be relieved, and we were the patients were also reassured that way. Another case where we can see, you can see there is a stone piece there present in the anterior chamber, and with a large tear. So we removed this after the tear repair, and usually there is a tendency to remove these foreign bodies, or fill the chamber through the main tear only. But I tell you, it should not be done. It should be done separately through the limbal port, like we remove the intraocular foreign bodies. The retina colleagues, they remove the intraocular foreign bodies. So this is again, but we could rehabilitate this patient. Patient had a fairly good vision after this the repair and surgery also. So this was almost 6 millimeter size foreign body with a 3.5 millimeter. So any corneal, my say for the traumatic cataract management is that if there is a simultaneous concurrent tear in the periphery away from the visual axis, you repair it, and repair should be offered by a no-touch technique. I don't hold the lip of the corneal wound with the forceps, try to avoid it, and we should use a Rouse-Hayes technique where the peripheral, the sutures are wider and the central one are smaller or less wide. So this will make the cornea, preserve the corneal asphericity, and not induce too much of astigmatism. After this, you can perform the cataract surgery, and if you are good enough in surgery, I will request you, in patients younger than 6 years or 7 years old, perform the posterior capsular access as we do it in our routine pediatric cataract cases. And if there is adequate capsular support, the lens is now buttonholed in the capsular axis, and then this eye will remain quiet, lens will remain stable and well centered, and the lens haptics and the tilting of the IOL will not be there. It is not going to touch the cornea or the iris, and UGH syndrome and all those complications are avoided. Cases with corneal tear,
please.
just last case, one last case. This is very interesting, if you permit, sir.
Yeah, please.
So, 26-year-old male came with us with a road traffic accident. There was a large tri-radiate Mercedes-Benz like sign like tear, and it was repaired first. Then we took it and we did a aniridia lens with glaucoma valve, because there was a glaucoma, persistent glaucoma for 11 months. This is post-surgery of MF glaucoma valve and aniridia lens, and the patient vision was 6/18 part. After 2 years, patient developed a decompensation. We did a keratoplasty and trimmed the tip of the AGV, and post-op, patient's best corrected vision at this time is 6/9. 6 years post primary surgery, patient is now happy. He's using one iotim and timolol maleate and lubricant, that's it. So, to conclude, every case should be independently assessed. A corneal or corneoscleral tear repair should be done first. Remove loose lens matter, foreign body, hemorrhage, exudates in the anterior chamber along with the corneoscleral tear repair. In case of suspicion of infection, irrigate anterior chamber with antibiotic. Give intravitreal antibiotic if you suspect the endophthalmitis in such cases. Manage iritis, glaucoma, infection, corneal surface, astigmatism before taking a patient for cataract and IOL surgery. And secondary IOL implantation is a good alternative. And we should always have a plan before going further with this complex surgery. Any intervention should be dictated by what is best for the eye, not by what is possible by you or you are able to do it. Be ready for any intraoperative surprises and anticipate problems that may occur, and we should always have a plan B ready to execute when we are managing these cases, as our ultimate goal is that it's not a good death but a good life to the very end. Thank you.